that they're making to that heart's tissue type, then we're doing it a little bit more cautiously and holding off on steroid withdrawal. The other thing that we're a little bit reserved about is withdrawing steroids on second-time heart transplants. And even though steroids carry with them a lot of side effects, they're still a marvelous anti-rejection medicine. And if you look at our long-term heart transplant survivors, they're all on a tiny dose of prednisone. So it seems to be a little bit of a wise thing to do in people that you think might be at higher risk for that. So antibody-mediated rejection is the type of rejection that causes heart dysfunction, but it doesn't show up on a heart biopsy the way cellular does. It means that, so say, okay, I'll give you an example. I'm a mom, a 3-time mom. So when I had my kids, my body senses those kids' tissue types. And so I may make antibody to their tissue types that they got from their dad. That's not my tissue type. Because you get your tissue type from your mom and your dad, half and half. So, okay, so I make those antibodies. It's just a normal thing. Or if you get blood products, you develop antibodies if the blood has, a different tissue type. So sometimes what happens is those antibodies that you make, they get very high when you're exposed to whatever it is, and then they go low, and sometimes they're undetectable. Well, all the hearts that we transplant, we do tissue types on them because in kidney world, they match your antigens. So you have certain markers on your cells, and they will find a kidney for you that has at least 3 of those markers that are identical, because that lowers their risk of rejection. That's why kidneys last so much longer and do so much better. But they have the luxury of doing that because they have dialysis to support you until you find a kidney that's at least a 3 or a 4 antigen match. So say I get a heart transplant, we don't do that in heart world because we don't have the luxury of doing that. We just match blood type and body size. So we put a heart in you, and one of the tissue types on that heart is something that you've been exposed to in the past, that you've developed antibodies to, but maybe they've gone to low levels that we didn't detect. Well, what your body starts doing is saying, I recognize that, and a second recognition is much more powerful and much more potent and much more difficult to stop. And once it starts, it's very difficult to get stopped. We can throw all kinds of things at your immune system, but, again, we've had another young man that he did great his first year, and all of a sudden he showed up with antibody-mediated rejection, and I think he survived, 4 months?
Why at 6 years?
He was at 1 year.
Why at 6 years?
I don't know. Because our immune system is amazing. We are marvelously and wonderfully made, as the Bible said. And, it's just crazy. Our immune system is so complex. Our body is so complex. And it's so smart. We've learned a lot from the AIDS population, quite honestly, because the research they've done to look at how the immune system works and how, it finds its way around things. But $1,000,000 question. And, sometimes we theorize that maybe your drug levels drop too low, and so all of a sudden your immune system kicks in and starts making these antibodies that it wasn't allowed to make when your drug levels are higher. But that's just a theory. Nobody's really been able to prove that. And why it happens at 6 years, why it happens at 1 year, why it happens, it's very difficult. And it happens more often in younger than older because our immune system diminishes with each decade of life. But it's $1,000,000 question, Joe. I wish I'd be probably pretty wealthy if I knew that answer. And the kidney people will tell you too that it's a wild goose chase to look at antibodies circulating in people because they're circulating in everybody. You can have, Arlene Thomas, who's over there doing great, her heart's doing great, and she maybe have all these antibodies circulating, but they're not doing anything to that heart. And then you look at somebody else and it's, eating up their heart. It's a very difficult process. It really is. So, and it's the reason that we monitor drug levels, because we do think, I had a patient who, I think it was year 2 or 3, came to us. He had lost a bunch of weight, So his liver started, metabolizing the ProGraf a lot faster, and his levels dropped. He got into fulminant rejection. We just about didn't get it, reversed. And it was just kind of out of weight loss and liver being better. And, it's kind of one of those weird things, Things happen, and it's again why we want to check blood work as frequently as we do, because we feel like we can at least catch it then. So, it's a good question though. Yes, ma'am.
So I may have missed it, but so you said that the antibody-mediated rejection doesn't show up on a biopsy.
Not in the way that a typical, so there's some staining that we can do to detect antibody-mediated rejection because it occurs in a specific way. It's kind of complicated, but what happens is the blood vessels start having a lot of inflammation in them, and you start seeing early blockages a lot more and a lot earlier. It is more of it's one of those diagnoses that's kind of the whole constellation of things. You'll see the heart function go down a little bit. You'll see these special stains light up, although they don't always. We'll pick up antibodies circulating that are very high levels. So we'll start, using higher powered meds to kind of treat it.
So it's really via the blood tests, if anything, that we even find this?
It's kind of heart function related, so we look at the echo carefully. So if we see the heart function going down by echo, and then the heart biopsy with these special stains, but that's about 50-50 because our stains aren't very refined at this point. And then we pick up the antibodies in the blood that's circulating that are very, very high. It does start out with very non-specific symptoms. I mean, the guy that we lost, he was 27 or 28. He called on a Sunday morning and said, "Lauren, I just don't feel right. I don't know what it is, but I don't feel right." And, she brought him right in. He got right in. He got put on ECMO almost immediately. He was in bad heart. We went from there down the tubes quickly. We, just like with Casey, we fired everything we had at him, got him a little bit better, got him off life support, but then he was miserable. It was terrible. So, and you just watch them linger, and you try, everything you've got, and you still see the heart just continue to fail, and he succumbed to, probably about 4 months later. It was terrible. So, it was a tough thing. So, it's a tough problem. And if you talk to the lung people, they fight the same battle. Antibody-mediated rejection is the number one tough thing they fight, because it's such a sneaky thing. It's such a, a little bit non-specific, but it ends with very, devastating consequences. So along with that, infection is still the number one leading cause of death in all transplants combined. We fight that early on, and we fight that long term. We've seen some of the weirdest infections you will ever see in transplant patients. Along those lines, though, we have a whole infectious disease service devoted to transplant patients. Since we do about 200 a year of solid organ transplants, we have the greatest guys on earth in our ID department helping us fight those, and you probably know a lot of them from being LVAD patients.
I was just going to say, he doesn't fight infection now, but before he had the transplant, there's no way he will get rid of the infection until he gets his transplant. But as soon as he got his transplant, he was fine. And
That is very true.
just trying to work through those things.
That's very true. We're going to get the hardware out, definitely.
Is that number one for the BJH
Everywhere.
everywhere?
If you look at the national statistics, it's still the number one leading cause. I feel like we do a pretty good job, just because we have such great ID
But
guys.
it's still number one for us too.
Yeah. Yes, it still is overall, if you look at it. And then our all-encompassing thing is that we really try to preserve kidney function, both for the short run and the long term. In heart failure, your kidneys really do take a beating, and so even when you get to heart transplant, you notice that your kidneys are a little bit diminished. So any little assault, can mean some big things in terms of your kidney function. So we're always looking at your kidney function. It's another reason why we like to get your labs every 3 months, because we like to pick up if we're going in the wrong direction. And then the long-term, challenges that we face are with kidney function. We have people that go on to kidney transplant. Really, when you compare it to heart transplant, it's a piece of cake. I mean, they make a little incision in the front, they put it in the front where it's nice and accessible. And kidneys do so many things. People feel marvelous once they get a kidney transplant when they've had kidney failure. The other number one problem that we fight is the blockages that occur in the arteries. It's because there's an inflammatory process occurring, and the way the body reacts is it lays down plaque in those arteries, so that's the reason for the cast that we do. It occurs almost universally at some point in everybody's life, whether it's at the 10-year mark, 15-year mark, 20-year mark, 22-year mark, and we really try to kind of fight it off. Malignancies is another issue that you'll all be prone to just because the immune system fights malignancies, so that's another reason to keep up on your other healthcare preventative stuff. Colonoscopies, skin checks, mammograms for women, prostate checks for men. It's the reason we do chest x-rays, I mean, everything. I see some smirks out there. We do also combat bone disease. We've had a lot of bad backs, a lot of bad spines, and, you know, crumbly bones. And it's the prednisone that we give that just aggravates that problem. So we're very active in sending you guys to ortho and physical rehab as well. Cataracts is another issue that can develop over time, and, you know, it occurs as a result of the prednisone therapy mostly. And then diabetes. Prograf long-term can actually make you insulin resistant, and some people will convert early to needing some form of diabetic medicine, whether it's oral or insulin, but it's always something we watch for every annual to make sure that we can try to control and treat when necessary. So that's kind of my thing in a nutshell. Yes, Ken Cooper.
I had two of those problems after post-transplant. So I went on dialysis afterwards, I became diabetic.
Yes,
I
so
was on insulin for just a very short period of time. Will that increase my possibilities?
that's a good question, actually. It's a very good question. Many of our patients and many of you come out of the heart transplant needing dialysis for us in the short run. It kind of depends on what your kidneys do in the first kind of 6 months, and kind of where the levels, you know, kind of fall out once you're kind of stable and everything's adjusted. Going through a heart transplant is rough on the kidneys. Going on the bypass machine is kind of an assault on the kidneys. And with heart failure, everybody's kidneys kind of take a beating. So when you go through the transplant itself, many people need to be supported on dialysis. It kind of depends on the extent and the length of dialysis that you need, whether you're going to have problems in the future. If you talk to our kidney doctors, which I would strongly advise that we try to get Brent Miller to this group. He's got a great talk on kidney issues, but some people are born with twice the nephrons of other people, and you don't know it until it's post-mortem, so we can't tell that. But some people's kidneys are far more recoverable, and I would say if your kidneys recover early on, meaning the first couple months, you're probably good to go, especially if your creatinine is, you know, around 1 or 1.5 or less. You know, but over time, everybody's kidneys do show some wear and tear with regard to being on the calcineurin inhibitors, the Prograf or the cyclosporin. With regard to the diabetes, almost everybody, because we slug you with so much prednisone IV at the time of transplant, it really makes your body resistant to the insulin that your pancreas puts out, so almost everybody needs help in that regard. It's not necessarily that you'll be more prone to diabetes in the future, but it is something we check at your annual labs as well. And if you've never had problems with it, chances are you won't have problems. But I will say that diet and exercise play a huge role in that. And if you can keep your weight down, and if you can keep yourself active, your body will use the insulin that your pancreas puts out much more effectively. And if you are Val's face is cracking me. If you can keep your weight down and keep yourself
I don't
exercising.
want to waste my heart. I don't do any of that. So I'm like, I tell this to Ewald. I was like, dude, I'm getting bigger. I'm lazy. He's like, oh, if I weighed what you weighed, I'd be so happy. That's literally what he told me. So I'm waiting for like that come to Jesus moment when it's like someone's gonna tell me, if you don't fix what you're doing, you're gonna waste your heart. It's like I keep hearing this and I'm like, when's it gonna like sink in? Because that is what I worry about, is that I'm just gonna keep getting bigger and then it's just gonna be like, oh, well guess what? All these things just happen. You know? And I mean, it's seriously, you know, I mean, and I say that seriously, like that is a huge fear of mine,
Sure.
but I am not motivated enough to do anything.
Well,
I
I mean,
go for seconds,
yeah.
but I
So
mean,
good.
that's at the point I'm at right now.
I know. I mean, it's a good question because it's something everybody struggles with. I mean, honestly, we all have, you know.
And even when I tell Ewald it's bothered me, he's like, oh, I wish I only
Well,
weighed
you
100.
see that belly on him. Come on.
That's on tape, you know.
I am in so much trouble.
We'll give you time code on that.
Yeah, there you go.
So yeah.
It is something. I mean, I tell people, even if your weight doesn't go down, though, if there's anything you can do to kind of increase your activity, because even if you're carrying around, if you can have some degree of, you know, take a walk every day, or do the stairs, don't take the elevators, you know, even if it's 6 flights, if it takes you a little bit, so what, you know, do the flights, and, you know, try to work it into your day. Park out in the parking lot, you know, and make yourself walk. Don't, you know, I mean, there's times when people need to do that, but, you know, anything you can build it into your day, it's honestly, you know, and I mean, I watched the metabolism guys used to come and give us lectures, and it's very depressing how much our metabolism diminishes with every decade of so
Yeah, get a Club Fitness
yeah, there-
membership. Okay, come on.
yeah, there you go. The Fitbit. Yeah, those will hold you accountable, that's for sure. So, it's frightening. Anyway.
The only thing that's lighter is your walk.
Any other questions or concerns or stories to share? Very awesome group you guys are. Well, thank you for letting us come to.
All right, let's hear it for the ladies one more time. All right, and then what did everybody think of the dinner? And the venue?
Very good.
All right, I think we have some announcements.
Yeah, I'll do announcements. The rest of you can go around the room.